getting close.
Okay. Is that okay?
Yep.
So I was trying to explain to my colleagues across the country what was special about this meeting. And I said, you know, the people, I'm getting some feedback from here someplace.
We're good.
Sorry?
You're tired.
Put the mic on your tie. Put it on your tie.
On the top.
Okay, we've got 20 suggestions.
That work?
Yeah, 20.
All right. So I was trying to say what was special about this group, and I said, you know, first of all, it's a lot of groups, a lot of large groups and integrated systems. There's a lot more people working in the commercial environment. But it comes down to the reality that it's a learning group. And I said that these people are hard-nosed in the kinds of questions they ask, but they're friendly and they want to do the right thing. And so with that, I'd say thank you very much for this chance to talk. And let me tell you what I want from the group, which is, I think, well-suited for this. The issue is feedback. And the last time I was here, saying, all right, as ABFM develops its strategy going forward, what I'd love is feedback about how we can be better aligned with large groups of various sorts. So what I'm going to talk about and go through a little bit about the world as we see it, and having gone through about 3/4 of a strategic plan, where we're going in general, and then what I think is value that we could bring to large groups. And that's what I'd love to have some feedback on today. Does that make sense?
Sorry, Richard. I don't really know.
Trying to check in on the airline.
So I think all of you have statements of why we're here and why the platform is burning, right? And one of the things that I've found most useful is, and I think it's the starting point for where ABFM is our current situation. And this comes from the National Resource Council about 3 or 4 years ago. And what I underscored to students and residents and many others is just where we are in the world. And the two graphs on the left-hand side I want to underscore. This is the usual comparison of America versus the other industrialized countries. The red dot is us. These are graphs of the likelihood of surviving to the age of 50 on the top if you're a man, and on the bottom if you're a woman. And in the 50, what you see is that in 1980, which is the left-hand side, we're comfortably in the bottom 20% of the industrialized country. And then if you're a man, we're now at the last of, this is by 2007, 2008. Look at what happens with women compared to the world. We've dropped off the curve in terms of the survivability. All of you, of course, understand that. But the other issue for family medicine is where are we as a discipline? And one of the things that I go back to constantly is the Future Family Medicine Report. And that if there's no big change in the healthcare system, and if we in family medicine don't fundamentally change our practice model, the role of family medicine in the healthcare system in the United States will be untenable in a generation. We're about half a generation in. I think you could argue that we've made some progress in that 10 years in terms of there's sort of our healthcare reform, and we've, I think, changed our clinical practice. But I think everybody in this room understands that there's a lot more we have to do. So let's start with data. That's disabled, not how it works. So let's start with data. And I think most of you know that the ABFM has put a lot of resources into the data available to us. And one source is data about what our diplomates are doing. It's about 92,000 diplomates, which is about 25,000 more diplomates than there are members of the academy. We also have started in recent years a graduate survey of all residents of the United States, and we have about a 65% response rate. So if you have been thinking of sociodemographic studies in which you get a 5 or 7% response rate, what we have is data that is an almost random sample with a 100% response rate. So there's pretty good data. What we observe is that now about 8% of family physicians in the United States are working full-time as hospitalists. That's going up 1% per year. It's actually, the urgent care has peaked and is beginning to go down. There are now 20% of our residents after 3 years who are not in continuity practices. So that's the probably most significant thing that we've seen. And that there are significant gaps between what we're trained to do, what we want to do, and the jobs that we are offered. And increasingly we're seeing, as family physicians become employed, there's a significant relationship between being employed, i.e. one of the kind of organizations that you're a part of, and higher rates of burnout, and a lower scope of care, scope of practice. This is an example. This is our data from residents. Again, this is all residents in the United States, where the blue is what people are prepared to do, and the, whatever that color is, orange, is currently practicing. And I think all of us know that there's a gap between maternity care in residency and beyond, but I'd underscore that it's much broader than maternity care. Looked at almost all procedures that relate to women's health, various kinds of hospitals. There's this big gap. And we've also done data about what people want to do and what they're doing, and there's a big gap. So it's training, it's what they want, and other things. So as we began to think about, well, what does the future look like all of you, we're impressed that both the rate and amplitude of change in the current healthcare environment is the biggest, certainly in my career. It's also impressive that it's unpredictability, that it's going in a lot of different directions. And we've talked about today the impact of consolidation, of employment, of new business models, AI and genomics, and the real question is sort of what's the signal and what's the noise and all this. Clearly it's a time of transformation. The way we've framed our strategic plan is, all right, if your frame is 15 years from now, and if your assumption that family medicine is the foundation of personal doctoring in the United States for the next generation, what does the personal physician of the future look like? And then what's the impact of consolidation and all of those factors? And then what we see ourselves as being in the role of trying to support personal physicians over the course of their lives. So what should we be doing? And that's what we're talking about. So moving forward, and this is a long process. We'll probably finalize it in a couple months, so I can't say this is 100%, but it's mostly where we're going. And my principle is I want to make a new announcement about every quarter. So the first one was, and given the context of the concerns about maintenance and certification and the relationship, is to begin to fundamentally change the relationship between ABFM and its diplomats. And meaning not so much you've got to do this and this and this, and don't worry your little heads, but we're with diplomats on their journey. Second, in July, starting the Center for Professionalism and Value in Healthcare. We are impressed, as we've gone through all the boards, is that there are huge lacunae around professionalism among the boards. So we think that this is critical to healthcare, not in the next year, not in the short term, but really important going forward. And then finally, in the fall and the spring is the family medicine, the longitudinal assessment. The importance of that is that it allows us to make the summative judgment. That is, does somebody have the cognitive expertise necessary to be a family physician who's board certified, and also provide an assessment that can drive learning. As we know from educational science now, it's assessments that drive learning. How can we support learning in our diplomats over their period of time? The next step is continuing professional development over the careers of our physicians. So our space is not medical school, it's not residency, it's the 30, 40, and 50 years by the time we end, between the time people finish their residency and the time they retire. And we work with a lot of players in this space. And what our focus is in, how can we support the learning of our diplomates. So part of it, many of you know that we put together knowledge self-assessments. About 60,000 diplomates every year use them. They actually are evaluated extremely well with kind of an average of 4.7 or 4.8. And about 2/3 of people who do one say it's going to change their practice. So what we want to do is to begin to refocus those knowledge assessments, to keep many of them, but then add timely topics to support breadth of practice, new practice areas, which we think are going to be critical for family physicians in the future, multimorbidity, behavioral health, that sort of thing, and practice transformation. And I've talked with David about this, but can we begin to address the kind of science basis and the research basis of family medicine to focus on keeping up to date? So a National Journal Club, the best model for this is obstetrics. And the notion would be you bring together a group of organizations and people like Dave and others and say, what are the articles that should change practice, that are high quality, relevant, and rigorous? Give each of our diplomates across the United States access electronically to those articles and perhaps other summaries, and say, here, diplomate, you choose the 25 that are most relevant to your practice, do some assessment and give credit, and make sure that they get credit for board certification. So the premise is keeping up to date, kind of evidence-based instruction. And then finally, and this is just small as an afterthought, but I think we really need to change all of CME in the country. Obviously, that's the role of the academy and academic organizations, but we have now well over 40 randomized controlled trials that says that this entire industry is ineffective. How do we change practice over time and really have contemporary pedagogy, so no more butts in the seat, and link it to clinical outcomes? So, this did not translate. Most of you know that another area is, for us, is developing measures that matter. So our conviction, all of you worked in quality for a long time, is that the metrics industry has not been appropriate for family medicine, that there's a lot of what we do in primary care that isn't captured by existing metrics, partly because we have too many of them, and partly because of the nature of it. And we are a qualified data registry, which means that we have the ability to submit metrics to CMS. We've now gotten CMS provisional approval for a continuity metric, and we're working on and testing a comprehensive metric. And the story is impressive. So we went to CMS, and Grant, you're going to be presenting, I think, on this a little. We went to CMS and they said it's a little bit soon. You only have a couple of, a few studies about the impact on continuity. And then our response was, well, how many metrics you have that control 20% of the variance of total cost, which is what a continuity metric does. And I think we've found similar things with comprehensiveness. So my point to you is, what are the metrics we really need, and how can we begin to shape? And I'm now reaching out, and we're looking for partners. Oh, it came up. And then long-term, meaning the last part of our first 5-year plan is, I think we all understand, at least I understand, having worked in this vineyard for a long time, and I'm sure many of you, is that we need a new approach to quality improvement. We think we need to rethink professionalism, and we also need, and I'm speaking to a group of CMOs and CEOs and the like, is we need to develop the next gen leadership development programs. How do we get family docs in the roles of the people in the room? So then, that's our thinking. When we think about, and it started in the conversation in September, what we're going to do that can be, I think, helpful for you, but I really would like your feedback about what you ideas came from our conversation with you the last time I was here. The first point is we need to be thinking about partnerships in a very new way. So the default representative for a lot of people in family medicine is a rural, independent, small group practice. That's a very important population group of practices, and we're not going to give that up. But the reality is that 70% of family physicians are employed. So the issue is how do we begin to work with employers as well as those docs? And so that's part of why I'm here. The second is, I think all of you are aware that there's an accelerating loss of the scope of practice among family physicians. It's not just a maternity care, it's children, it's procedures and a variety of other things. And that there's this really interesting initial relationship between being employed and being burned out and having a lower scope of practice and being burned out with all the transition costs of that imply. So the implication for us is that we've got to partner in some way with systems. So what are we all doing? What are we doing that I think is of value? And part of this comes out of our conversation in September is one of you said, one of the most useful things you can do for us is give an independent assessment of cognitive expertise. We, meaning what he was saying, have a hard time doing that, and it's a political process often. I already mentioned the KSAs that are there, and I think we have a lot of work to do in communicating the changes we've made with our quality improvement modules and ongoing initiatives. All that is what we're already doing. And there's a lot of work to make it better and communicate it better. But then the second part is, all right, how do we begin to support professional development of your physicians? And we think that if we take our knowledge self-assessments and begin to frame them to help family docs keep scope, like one focused on child care, child health care, focused on new areas like multimorbidity or behavioral ed, that as an on-ramp. What several of you said is, we're doing a lot of quality improvement ourselves. So yes, we understand that you're going to give us credit for that, but we need two things from you. One is we'd like on-ramps. We have people coming in who are joining our practice who don't know what value-based care is. They don't know what quality improvement. Give us some materials that they can do. The other part is, can you use the fact that you work with every organization in the country to begin to curate change packages for various changes in the practice, for if you want to use a particular metric. We've mentioned the Journal Club. What we're beginning to see, and we're thinking about exactly how to design this, is that within systems, these become internal conversations about what do they want their best practice advisory prompts in EPIC or whatever, so that you have data that can inform discussion, and probably new versions of CME within systems. And we've already mentioned the change packages. I think, where do we go with quality improvement? Many of you know that I've been working for a long time in this, and you can't say that the glass is full. I'm not sure it's half full. I'm not even sure it's quarter full, but we have made some progress in 15 years. And what strikes me as I hear the national discussion is just, are we really any better off 15 years after innovation and transformation and whatnot? I was talking to Beth McGlynn, and many of you know her. She's now at the new Kaiser Medical School, and she did the classic studies from RAND. So I was saying that, no matter where we are in healthcare, in the hospital, in primary care, in the health department, we do what everybody agrees we ought to do about half the time. The question we're in there, all right, how are we after almost 15 years after she published that stuff? She gets asked that all the time. RWJ was going to fund and gave them $1 million to fund the next study, but they decided that social determinants were more important, so we're not going to find out whether or not we've made any progress. But she doesn't think we've made any progress at a population level since then. Professionalism assessment. Right now, we use as a measure of professionalism, and this is not I mean, all of you have credentialing organizations. I'm not sure this adds too much value to you. But what we use is a full license as our measure of professionalism. What's evident is that, for example, there are other measures that are important, like CMS has a list of people they will not pay because of fraud. To me, that's a pretty good example of a problem with professionalism. We also think, and this is a page taken from medical education, is that can we begin to identify positive elements of professionalism? The narrative that is out there because of what we're using is those bad doctors. There's also doctors who do remarkable things in their community and other sorts of things. And how can you begin to make it a mixed picture? And I already mentioned the leadership development. So the long term is, all right, where do you go? And this is probably in the second 5 years of the strategic plan. But I mentioned this a little bit earlier today, but if you look across the board, we know that there are burning issues that none of the boards deal with. One is communication skills, except for new anesthesiologists. Another is diagnostic. I mean, we think that something like a quarter to a sixth of the cost of care in the United States is because of diagnostic error. How do you get at that? A big issue at the AMA in the last couple of years particularly, but other places, is when do you stop doctoring, particularly if you're on the cognitive side of the house? We begin to have data where you can begin to say that. We're going to have to say that, as you know, our data show that doctors are practicing longer. How long should they practice? We're probably not practicing as long as the general surgeons, whose national workforce estimates say that, you know, that the average general surgeon is retiring at age 76 in the United States. But the other issues are right. We've been accrediting teams of doctors. That's what we do. We do a certification. What about teams? There's more and more evidence that with surgical teams, and I'd argue primary care practices, it's the function of the smaller unit that's the key thing. Should we be accrediting practices or teams in some way? And then finally, given this emerging relationship between employment and burnout and scope, can we begin to say, let's find exemplar systems that are doing it right, not just within the redesign, but the organization of primary care within the large system and scope of practice. And what we'd like to have is a learning collaborative where we test and develop and spread measures, but also interventions aimed at reducing turnover and increasing comprehensiveness. So with that, I'd love to hear comments and suggestions.